for a small man like me. It's my pleasure to actually take this topic, patient monitoring in ICU. And I would like this section to be an interactive one. So if at any point in time you are no longer able to hear me, feel free to actually indicate. Thank you once again, and happy new moon. This is this session, this month. Happy new month. So permit me to share my slide shortly. Can you see my screen now?
Yes, we can, Mr. Fatai.
Yes, of course we can.
Okay. Okay, once again, let me introduce myself. My name is Fatai Ekundayo. I'm a staff of David Umar University, Federal Medical Sciences. Okay, before I continue, I would like to actually, these are my outline. I would like to actually try to actually, let's do a little exercise. Can you still see my screen?
No. No, we can't.
Okay. Can you see my screen now?
Yes, it's back on.
Yes.
Okay. So assuming you walk past, okay, you are a physiotherapist, a medical doctor, a nurse. So imagine walking into an ICU. What are the first thing you notice that this is an ICU, or what are the things that would tell you that you're actually in ICU? So I would like to hear from us. Please I will read from the comment section, drop what you know as, okay, what we tell that you're actually in an ICU, what you will see, and you will know that you're actually in an ICU. So we have 3 minutes to actually tell us what's the indicators that tells us that we're actually in an ICU. I can see Amici Eunice saying the monitor. Okay, Joy, mechanical ventilator, we definitely. Okay. Grace said the monitoring machine. Okay. And we all are correct. In fact, personally, the first thing that tells me that I'm actually in an ICU is the beep sound. Does that alone traumatize me? So you can actually see the alarm machine. You can see the machines, the ventilator, the X-ray machine, the lab machine, the monitors, and then the multiple disciplinary team is made up of the doctors, the nurses, the physiotherapists. They all constitute the part of the ICU. Okay. Blessing says the sound. Okay. They're all made up of that. Those are the indicators.
Okay. Yeah.
Okay. This is off. Okay. Those are the things you will see, and you will know that actually you are actually in an ICU. So 1 minute, let me have my slide again. Can you see it now?
Not yet. Okay, it's back on.
Like I said before, you will see the monitors, the machines, which includes the ventilator, the suction machine, the X-ray machines, the lab machine, and so on and so forth. Then the hallmark of it all is the alarm, the beep alarm that comes from the machine. At least if you've been in ICU for some time, even if you're not in the ICU, you will still be hearing something like ping, 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 ping. And then also the teamwork, the multidisciplinary teams are made up of the doctor, the therapists, the nurses, the dietitians. They all constitute part of the ICU team. So now, before we talk, what is an intensive care unit? Can you see my screen?
Yes, we can.
Okay, now before we continue, what is an intensive care unit? Okay, intensive care unit is actually made up of multiple disciplinary teams that monitors the patient 24/7 with a sophisticated devices and protocols. So the multiple disciplinary team is made up of a defined roles. Now, in ICU, everybody actually knows what he or she is there to do. As a therapist that works in an ICU, I can't just go into the ICU and start doing the work of a doctor. So as a therapist that also works in an ICU, I can't just go there and start doing the job of a nurse. So we all work hand in hand. Now we we all know our job description. You can't just go there and start doing the role that is meant for other units. So we work hand in hand. So now the main goal or the main aim of an ICU is to stabilize patients, prevent further deformities and the deterioration, and support recovery. So now the typical component of an ICU is actually the ICU is made up of the patient who is critically ill or hemodynamically unstable, or a post-surgical patient, and then the teams including the medical doctors, the therapists, the nurses, the pharmacists, the dietitians. Then the equipment includes the monitor, the ventilator, the infusion pumps or syringe pumps, and then the suction machines. Then the environment alone is what we say that you're actually in an ICU. The continuous alarm that comes from the monitor, the invasive and non-invasive line, then the strict infection control measures, which includes the therapists, the doctors guiding themselves properly by putting on nose masks, protective gears when they want to take an X-ray, because you won't say that because you are working in an ICU, you now become a patient yourself. So now, the main focus of an ICU, like I said before, is for continuous monitoring to support organ failure and then multiple disciplinary cares. Then this takes us to the main topic of the day, which is a patient monitoring in ICU. Please, can you mute your mic, please? Oluwadotun, please, can you mute your mic, please? Okay. So now this takes us to the topic of the day, which is a patient monitoring in an ICU. Patient monitoring involves the intensive and continuous and measuring of the vital signs, parameters, or signs to detect early changes and guide, which will also guide our intervention. So the first question we should ask ourselves is why ICU monitoring? The importance of ICU monitoring. Before and during any mobilization or respiratory therapy section in the ICU, patient safety is the topmost priority, which includes the real-time vital responses, preventing clinical deterioration, communication and documentation. I will actually tell us real-time stories or first-hand experience I actually experienced while I was in ICU. I was at the patient bedside trying to actually do suctioning. It's not even suctioning. We went there to do mobilization, to do our normal PM, STM for the patient that have been on the ICU bed for a very long time. Now we now notice that while moving the limb, the SpO2 keep going down rapidly. In fact, we actually stopped. When we stopped, the SpO2 keep going down on daily basis, keep going. And we keep wondering, why is the SpO2 going down? Not until when my chief walked in, I was like, can't you guys see that this patient is actually hyperventilating, struggling to breathe? And then by just normal suctioning, the SpO2 return back to normal. So now, the real-time monitoring is just the hallmark. Monitoring your patient pre and post is the key. Knowing when your patient changes, knowing when the vital signs goes down from the normal, and then knowing when what you met the patient with, assuming you walk into and then the SpO2 is actually is 98, and you started mobilization, and the SpO2 keep going down, kept on going down, it's actually an indicator for you to stop and then know why the SpO2 is going down rapidly. Mobilizing the patient means that mobilizing the patient can actually cause the SpO2 to go down, but not so rapidly for it to actually go from 98 to 88. So now it's an indicator for you to know when to stop and then shake. And then the main reason why these monitors are there is just for the real-time monitoring of the patient's vital signs. So you don't have to start checking the blood pressure, start checking the SpO2. So as you're mobilizing the patient, as you're observing the patient, you are seeing the real-time vital responses, the real-time values on the monitor. And then it's an indicator for you to know when to stop and then know when to actually call it a quit in the ICU. So now, why, like I said before, why ICU monitoring? Why does it matter? You monitor the heart rate, you monitor the respiratory condition under this. Now, in ICU, even if you don't know anything, you need to actually know the art of documentation and art of communication. Knowing when to actually call on the next available person to take over. Knowing when your job ends and then when another person's job begins. You can't do the job of a physiotherapist and still do the job of the nurse. So now communication and documentation is the key. Is the key in ICU and also in patient monitoring. So you have to document every single thing you do in ICU. No, why you document is that so whenever anybody that takes over from you, we know what you did for the patient, and then what you didn't do for the patient, and then know the vital signs you made the, and then know the vital sign when you met the patient, and then know the vital signs when you left the patient. Then this will also enable you to actually keep track of your patient, know when your patient is actually deteriorating, know when to actually call on the next available, when to call for help. Please mute your mic. So now, according to Vincent et al. 2021, said early recognition of abnormal trend reduces mortality rates by 30%. And then continual monitoring helps to optimize therapy, prevent further complications, and also improve patient outcomes. The multimodal monitoring, which includes the cardiac, respiratory, and hemodynamic values, and also the neurological values, is associated with better prognostication and individualized care. This is according to Singer et al. Now, no two patients are the same. You have Mr. Nnamdi in bed A and then Mr. Sam in bed B. You won't do the same thing you are doing for Mr. Nnamdi for Mr. Sam because they are actually different individuals, different patients. And then Mr. Nnamdi might actually be having a TBA, traumatic brain TBI, traumatic brain injury, and then Mr. Sam might actually be having a sepsis. So now you won't be doing something. You won't be doing what you are doing for Mr. Nnamdi for Mr. Sam. So knowing what to do for each patient is actually the key. So thereby you actually individualize the care for the two different patients for a better prognosis. So now ICU monitoring system improves response time and reduce adverse effects. This according to Kuma et al. 2020. So now the global burden, over 20 million patients are actually admitted into ICU annually, either in one way or the other. Then the mortality rate in ICU ranges from 15 to 40%. But structural monitoring, increase or improve survival rates. So now the objective of ICU monitoring, or the aim of ICU monitoring, this is more like a man map. So now early detection of this physiological derangement can actually help you to actually make your clinical decision, or also guide you for clinical decision. Then when you make your clinical decision, you document and communicate. You don't just make your clinical decision and then you just continue your care without you continue the patient management, or you manage your patient without actually documenting or documentation. So now you document every single thing you do, and communication. So like I said before, I also mentioned documentation and communication earlier on. Now, documentation and communication is part of the medical legal issues that can actually land a medical personnel into trouble. So every single thing you do for the patient, you need to actually document and communicate properly to the proper channel. Now, even if you check the vital signs, and by 10 o'clock, you document 10 o'clock, vital signs, the blood pressure is this, the respiratory rate is this, the heart rate is this. Then you document, proper documentation is key. Now, evaluation and treatment. So now you always evaluate based on what you document. So this will also guide your treatment effectively. And then when you actually plan your treatment based on what you document, and then from the clinical decision you already made earlier on, this will also help to actually prevent complications, prevent hospital stay. Then the person can also be weaned off oxygen and then move to the normal ward on time. So now early detection, like I said before, early detection helps to actually identify life-threatening changes in the vital signs. Then continue monitoring, reduce the risk of unrecognized deterioration. This according to Vincent et al. 2021. So like I said before, you saw I always make mention of citing articles, publications, because now whatever we do, you need to actually make sure that it's actually evidence-based, it's documented. Because once you do anything and someone comes and asks you, why do you do what you do? You will say, because this is actually an evidence. It has been done before and it has been proven to be effective. You can't just sleep and wake up one morning and start treating your patient without actually using an evidence, or actually an approved guideline probably based on WHO, or based on the based on an evidence, already existing evidence. Now, the guidance for clinical decision making provide disparity. So now, as a physiotherapist, if I document my vital signs as of 10 o'clock, and a medical doctor actually goes through the case note and also see that I documented as of 10 o'clock, and then know that the patient vital sign is actually this in the morning, and then when he came, he saw something else. Then this also helped him to actually guide him. This will guide him to make proper assessment and then plan his treatment too. Not just for physiotherapists alone, but for all the multiple disciplinary teams that actually manage the patient. Because a medical doctor alone does not own a patient. A physiotherapist alone does not own a patient. A nurse does not own a patient. And the patient is being owned by the multiple disciplinary team. You can't just come and start saying, this is my patient, leave it for me. Now, if they leave it for you, you can't actually manage the patient alone. You still need the help of all these professionals to actually manage the patient. Now, evaluation and treatment effectiveness. This allows us to actually monitor the real-time assessment and also plan our interventions. So now, facilitate therapy optimization. This is according to Kuma et al. 2020. So now, like I said before, it helps in prevention of complications, prevent hospital stay, and then reduce the risk of death too. Now, these are the principles guiding the effective monitoring in ICU: accuracy and reliability, timeliness and continuity, integration of multimodal data, individualization, human oversight and clinical judgment, early warning and escalation system. So I will take this one after the other. So now, accuracy and reliability. Monitoring devices should provide precise and reproducible measurements. Now, false alarm or inaccurate can lead to delay or inappropriate care. So now, like I said before, those machines you see in ICU is a standardized machine that reproduces the value, come rain, come sunshine, at any point in time. It gives you the real value, because when it starts giving you false value, it can actually lead to delay or inappropriate care, by actually delivering the wrong care, the wrong treatment, or the wrong intervention for the patients. Now, those monitoring devices is there to actually help you make the proper decision for the patient, plan your treatment that would be beneficial for the patient. Now, timeliness and continuity. Continuous monitoring ensures real-time detection of critical changes. Like I said before, ICU is not where you go, you switch on and off. You don't just go you don't just go there in the morning and then dismiss in the evening and go back home. Now, if you're living an ICU, you must actually hand over to somebody that will actually stay there, because ICU runs on 24/7. It's run for 24/7. So you must actually hand over to somebody. And then you don't just say that, okay, this person is coming in the next 30 minutes, let me just quickly rush out and then come back. No, you must be there, because anything can actually happen at any point in time. In seconds, the patient might actually leave you and go. You might leave the patient, you might actually not say, let me just quickly rush and go, and then they will start shouting physiotherapy, physiotherapy, physiotherapy. By the time you come back, you see that the patient have actually packed and go. Now, they will now be saying the physiotherapy killed the patient. They'll be looking for physiotherapists. Now, you must actually be there on time at every point in time. Now, you also document. Now, documentation, it means that if you are documenting, you are handing over so that the person that will continue from you, we know that this is what the patient did. The person that handed over to me did for the patient in the morning. So this is what I'm supposed to do for the patient. So if I'm actually doing based on what the person handed over to me. I can't just come in the afternoon and then start planning my treatment afresh, thereby actually abandoning the patient what the therapist have been doing for the person since morning, and then now continue and then abandon it, because now there are some changes that have actually occurred from morning to when they handed over the patient to me. So I will need to actually take over from where the person that handed over to me stopped. Now, integration of multimodal data. So now combining vital signs, lab results, imaging, improve diagnostic accuracy. Now I can't just come into the patient. I can't just walk to the patient-based signs and then check the muscle tone, check the muscle strength, check the reflexes, and then say that the vital signs are none of my business, or the lab results is none of my business, or even the imaging results is none of my business. So now in ICU, you make use of all the multimodal data. You look at the vital signs, you look at the lab results, you look at the imaging results. All these things will help you to actually make the best or the right decision that will actually help the patient and then improve care for the patient, because we all are there for the patients. And so we actually have to take a look at all the available data, including vital signs, the lab results, the imaging results, so that we can actually make an accurate decisions that will actually help the patient and then win the patient off the ICU and then move the patient to the ward. Now, individualized care. Like I said before, you don't just come and do what you did for Mr. A for Mr. B. Now, you can't be giving the treatment meant for a patient with hemodynamic or shock for TBI. You can't be giving a patient with TBI hemodynamic intervention. Now, you actually individualize their treatment, your interventions based on their condition and their presenting complaints. Now, avoid unnecessary data overload and focus on the relevant parameters. This is according to Marek et al. 2017. Now, a patient in ICU, you can't just come and start doing muscle strengthening, start doing positioning for patients with unstable vital signs. Now, you focus on the relevant parameters, the relevant issue, try to actually address the key issues, the key vital signs that is the problem, before you start focusing on other vital signs. Now, patient with respiratory issue, all you need to do is just to actually improve oxygen airway, increase oxygen exchange. Now, you can't just come and start doing what's it called, the PM, STM, you understand, mobilization, positioning for a patient with that is still struggling to actually stabilize, that we are still struggling to actually stabilize the respiratory rate. So now you actually focus on the relevant parameters at that particular point in time. So now when you know that the patient is now stable, that's when you now start incorporating other things like preventing pressure source and other things. But at that particular point in time, you focus on the key parameters, that is the issue or the key issue facing you at that particular point in time. Now, early warning signs and escalation system. So use of the scoring systems. We have the early warning signs in ICU. So now, and then the SOFA signs too in ICU. So this helps you to actually predict this deterioration, and then you guide you for escalation of care. Now, this according to SYNC 2016. Now, in ICU, if you're actually managing a patient and you notice that the patient is actually going down, the SpO2 is going down, You don't just come there and then start keep doing what you are doing. You escalate for help. You reach out, you call for help. Now, because if you don't call for help, if the patient dies while you are just managing the patient, what will be just beyond that? If physiotherapy kill the patient, Dr. Tayo kill the patient. You understand? So at that very point in time in ICU, you know when to call for help, know when to seek for help. You can't just come there and start because you don't own the patient alone. It's a multiple disciplinary job. It's a multiple disciplinary duty, in which includes the doctors, the nurses, the dietitians, the lab, the radiographers. So at every point in time, you know when to call for help. You don't just sit there and kill yourself. So now, human oversight and clinical judgment. Monitoring data should support, not replicate clinical assessment. Now, but you actually monitor your patient does not mean not do your clinical assessment. Now, like I said before, human oversight and clinical judgment. Monitoring data should support and not replicate clinical assessment. I came into the world and I just went to the monitor, took the vital signs, took the heart rate, respiratory rate, blood pressure, and then and I will now say that I'm done with the patient. No. Now, there is need for you to actually do your clinical assessment. So patient monitoring does not replace clinical assessment. You do your clinical assessment, starting from the head and neck, down to the lower limb. You check the vital signs, you check the GCS level, you check the muscle strength, you understand? So you actually do an holistic assessment for the patient in ICU. You won't just come and start saying, I've taken the vital signs, and I will now go and sit down. Now, by doing the clinical assessment, we also tell you the underlying conditions that the patient is actually facing. You understand? It also help you for your money for plan your intervention, plan your treatment effectively. So now, effective teamwork and communication are essential for safety. This is according to SSM 2022. Like I said before, you don't just come and then go kill yourself while managing the patient. Know when to escalate, know when to come for help. Then you stick to your job description. You don't just come there and you start doing the job of a nurse. You don't just come there and then start doing the job of a lab scientist. But then you need to naturally know what each of the disciplinaries are doing for the patient, because you also own the patient. You understand? If they are taking the blood sample, you know what the blood sample is for. If they are taking the X-ray, you know what the X-ray is for. If the nurses are actually checking the urine output, you know what they are looking out for. Now, you don't just come and say, hey, let me just go and do positioning. Then I will go and sit down. My job have ended. No. No, you look at what actually know the reason why they are, you know the reason why they are collecting the blood sample. Now, because most of these blood sample in one way or the other still affects your treatment. You understand? Now, some drugs might actually also has an effect on the patient. A doctor might come now and keep giving the patient sedative. Now, which will in turn affect your treatment protocol as a physiotherapist. It's your duty to actually walk up to the doctor and say, oh, this is what I'm doing for the patient. You are giving the patient sedative. Now you come to a conclusion. Now you guys will actually reach an agreement, and then know if the sedative helps the patient more. You understand? Then you know how if you have to actually reduce your intervention or increase. Now you can also reach out to the sedative you are giving this patient is actually affecting my treatment. So should you reduce it? You understand? You actually plan and then or you change it. So now it's your duty to actually reach out and then know what each and every multiple disciplinary team in the ICU and what they are doing for the patient. This also plan and then also help you to actually plan your intervention. And then you also help you to know what you should do for the patient. Then you don't just go and sit down and then say, I'm done with my PM for today. Let me just go and sit and then be looking at the monitor and be checking when the SPOT is going down. Check when the BP is going down or going up. You don't go and sit. No. If they are doing ward run, you actually join them and then know the reason why they are doing whatever they are doing, their intervention. You know the reason why they are planning. You can also suggest, I'm doing this for this patient. I don't think this is actually relevant for the patient. Should we interchange this with this? Should we do this for this? So now this is why they call it multiple disciplinary in the ICU. Now we now have level of monitoring in ICU. We have basic monitoring, we have advanced monitoring, we have specialized and multimodal monitoring. Now, patients can actually move from specialized multimodal monitoring to advanced monitoring, and then from advanced monitoring to basic monitoring. And then from basic monitoring, the patient can actually be discharged from ICU and then be moved into the ward. So now from specialized to advanced and then to basic monitoring. So I will go into one after the other. Now in basic monitoring, there are some basic and key parameters you look out for. In basic monitoring, you monitor the heart rate, you monitor the blood pressure, you monitor the respiratory rate, the temperature, and the SpO2. So these are the key basic parameters or vitals you actually monitor. Now, at every point in time, in whatever you are doing for the patient, because now physiotherapy affects vital signs a lot. If you are doing PM, your PM affects the heart rate, your PM affects the blood pressure, your PM or STM affects the respiratory rate, your PM affects the temperature, and then also affects the SpO2 the most, because as you are doing, the patient actually there is increase in energy expenditure and also the increase in SpO2 use. So now it is now left for you to know when the patient is actually experiencing
I can hear you again. No. God, I cannot hear you.
increase is actually more than above actually.
Please, I can't see the screen again. No, neither can I hear you.
I can't hear him too. I don't think he's online.
Okay.
No lectures.
So hello, sir. Please, we can't hear you. Where is the copy of that?
I think he left the meeting.
Hello? Please let me
I'm
Hello,
contact
saying
we
I
can't
him.
think
hear him. Oh.
Let me contact him.
he left the meeting. It
Please, you will
could
jump
be
back
his
shortly.
connection.
You will jump
It
back
could be
shortly.
his connection that's poor.
He will join back shortly.
Hopefully.
He's
Can you
back
hear me
on.
now?
Oh yeah, he's back.
Please, where did you stop? Let me know where to go back. I'm so sorry.
The basic level of patient monitoring, the key vital
Okay.
signs.
Okay, the basic level. Okay, let me share my screen again. Okay, let me go back. Okay, can you see my screen?
Yes, we can.
Yes, we can.
Well, like I said before, we have three levels of monitoring. We have the basic monitoring, we have the advanced monitoring, we also have the specialized and multimodal monitoring. Now, a patient that is actually in specialized and multimodal monitoring can move to advanced monitoring. And then patient in advanced monitoring can be moved to basic monitoring. And then from basic monitoring, you move the patient into the ward. So now, for the basic monitoring, we have the key vital signs you look out for. We have the heart rate, the blood pressure, the respiratory rate, the temperature, and the SpO2. Now, for the clinical observation, you observe the consciousness level, which using the GCS, which is the glaucoma scale. You also check the skin color, you check the urine output. Now, this is recommended by the World Federation of Society of Anesthesiology. They say this is the minimum monitoring standard for every patient in ICU, either in advanced, basic, or multimodal level. So now this is the basic and the minimal level of everything, what you need to actually check for the patient. You check the heart rate, the blood pressure, the respiratory rate, the temperature, and the SpO2. Now, for the advanced monitoring, for patient in advanced monitoring, the patient you see in advanced monitoring is patient with organ dysfunction or organ instability. So mostly they pass the invasive arterial pressure monitoring. They do the invasive arterial pressure monitoring, which is the A line, the central venous pressure. They also do the SpO2 monitoring. Then they also do advanced respiratory monitoring, where they check the ventilator waveforms and the end tidal volumes. Then they also do the neurological monitoring, which is the GCS, the pulmonometry, the intracranial pressure monitoring, where they actually check the level of the intracranial pressure. Then this provides the real-time data that guides our clinical decision making. Now, for the specialized and multimodal monitoring, so now this includes the complex and high-risk patients. So now where they check the cardiac output, they do cardiac output monitoring, which includes the electrocardiograph, the PICO, the pulmonary artery catheter. They pass the pulmonary artery catheter. They also do the cerebral monitoring, where they do the EEG. They also check the brain tissue oxygen. They check the oxygen level on the brain tissue. Now, they also do the renal metabolic monitoring, where they do the continuous renal replacement therapy data. They will do lactate clearance. They also check the advanced. They also do advanced electrolyte check for advanced electrolyte imbalance. So now, increasing income. So in some advanced countries, they also incorporate AI-based predictive analytics, where they tend to actually predict what is actually wrong with the patient using tele ICU for precision care. This is according to Kuma et al. 2020. So this is the key vital signs, and then if you go to the ICU, you need to actually know the normal range and then know when the patient is actually going or actually moving out of the normal range. Now, for the heart rate, the normal heart rate is between 60 to 100 beats per minute. So now anything less than 60 or greater than 100, there's an indication for problem or probably an arrhythmia. Now, for blood pressure, the systolic blood pressure is between 100 to 140. Now, for diastolic blood pressure, for the diastolic, so what I said initially was systolic blood pressure. Systolic is between 100 to 140 millimeter mercury. For diastolic, is between 60 to 90 millimeter mercury. So now, for the diastolic, if diastolic is less than 100 or greater than 140, there is an indication for a proof that something is wrong. Now, for the mean arterial pressure, is between 70 to 100 millimeter mercury. So now 65 millimeter mercury or 110 millimeter mercury is an indication for danger. Now, if you look below the screen, you will see what the green means safe, while the orange means caution, and then red means stop and caution. Now, when it's in the green zone, it means that you should continue your care. you are doing the right thing, you are on track. Then when the thing starts, then you know that this thing is actually moving to the dangerous zone. Most times you actually continue, but you have to be cautious. Now, when the thing has moved to the red zone, now let me take the heart rate for instance. If you come to the patient bedside and the patient and the heart rate keep pulsating between 160, 165, 170, and then you started your PM, you started your mobilization, and then the thing keep dropping to, and the thing keep dropping to from 170, it kept 55. You keep on managing your patient. There is no cause for alarm yet. But once you start seeing 150, 145, it's actually an indicator for you to stop and then know if your treatment is what's actually causing the reduction in heart rate, or probably if the heart rate is actually increasing. So it's an indicator for you to know when to stop. And then as we are managing your patient or treating your patient in ICU, your eyes should always be on the monitor. You don't tell somebody to look at the monitor for you. No. You always look at the monitor and then know when to actually call it a quit and then when to call it a stop. Now, because every patient in ICU are critical patients, so you actually have to take critical measures and actually be careful in whatever you are doing with your patient in ICU. So for the end tidal volume is between 35 to 43 millimeter mercury. So less than 25 is an indication for danger. Then greater than 55 is also an indication for danger. Now, for the temperature, 36 degree to 37.5 degree centigrade is the normal range. Now, once it goes below that, and you start seeing 38, greater than 38.5 or less than 35, is also an indication for you to actually call for help. Then the intracranial pressure. So any intracranial pressure is less than 15 millimeter mercury. So anything greater than 20 to 25 millimeter mercury is an indication for danger, and then you need to actually call for help. So now for the level of consciousness, you check the level of consciousness using the glycosomal scale. So we already know that 15 over 15 is the normal value. So anything less than or equal to 2 is a point or unresponsive range. So now research evidence supporting ICU monitoring. Like I said before, you don't just come and start checking vital signs and then start mobilizing without having an evidence supporting whatever you are doing in ICU. Now, if you're managing the patient, you don't just come and say, my chief said I should do PM for the patient. Now, you need to actually, one day you also become a chief. You need to actually know what the evidence is saying out there, and then the available evidence, what the data is saying out there. Now, in 5 years to come, there might be new evidence overruling the evidence that was established 5 years, 10 years backward. Now, you need to actually keep yourself in track and then keep yourself in check, knowing what the real data and the new evidence that's actually out there. Now, because on daily basis, new data keep on emanating, new data, new treatment protocol keep on coming up. And then all these things is actually there to actually guide you to actually improve and plan your interventions for the patient recovery. Now, for the vital signs, early warning indicators, this is according to Sube et al. 2018. Early warning scores based on basic monitoring reduce the ICU mortality rate and then unplanned admission. Now, for the neurological monitoring, this was supported by Tesdale et al. 2014, and it said that IGCS remains the gold standard for neurological assessment in critical care patients. So now tomorrow I might wake up tomorrow and then set up another gold standard for actually checking the neurological assessment in ICU, and the people will keep starting. Probably you might see Fatai et al. 2025. Which is now the gold standard. Probably I might actually see a loophole in GCS measures, the glycosomal scale, and then actually establish and standardize one now. Now, tomorrow, another person might actually see a loophole in my own scale and then establish its own. So now, like, according to Tesla et al., and then there is nobody have actually disputed the fact that GCS still remains the gold standard in neurological assessment in ICU. Now, for the food and electrolyte imbalance monitoring, this was supported by Vera et al. 2012. Positive fluid imbalance independently is associated to ICU mortality rate. Now, temperature and infection control. This was supported by Singer et al. 2016. Abnormal temperature is a diagnostic criteria in sepsis guideline. We all know that temperature is associated with sepsis. Now, for pain and comfort, the VINE itself established a PEDIS guideline recommended for routine pain check, agitation, delirium assessment in ICU patients. Now, the basic physiological parameters include the eight. So number 3 is the SpO2, 83. Then number 4 is respiratory rate. Then number 5 is the vital record. Then number 6 is the respiratory waveform, which is the who tells you the waveform of the respiratory of the patient. Now number 7 the SpO2 waveform of the patient. Then number 8 is the ECG strip. Then number 9 is the alarm. So now in ICU, each alarm has its own meaning. Now, if you come and you see pim, 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 it shows that everything is normal. When you start hearing pim, 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 it's an indication for danger. When you start hearing continuous pim, 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 it's an indication for danger. So it calls on the attention for you to actually look at the monitor and then know what is wrong. It's either the heart rate is actually going down or increasing, or the blood pressure is increasing or reducing, or the respiratory, the oxygen saturation is actually going down. Now, this the when the alarm keep on beeping, it's an indication for you to actually look for is a call for attention for you to actually look at the monitor and then know what is wrong what is wrong with the patient. Now, like I said initially, I said we have the basic physiological parameter monitor. We have the heart rate. We have the cardiovascular. Under the cardiovascular, we have the heart rate and rhyme. This is the continuous ECG monitor that detects the arrhythmias, ischemias. Now, for the blood pressure, we have ICU. Now, for the respiratory, so early deterioration. Oxygen in the respiratory indicator, you check the oxygen saturation, which is the SpO2. You check the end tidal CO2, which is useful for the ventilator, which is useful in ventilated patient and during resuscitations. Now, evidence says that SpO2 and EtCO2, which is the end tidal CO2, are critical in guiding ventilation. Then this is also an indicator for you to actually know when to wean the patient off the ventilator. It's either or know when to actually change the ventilator mode, either in continuous mode or the pulse mode. So now the SpO2 will tell you that and then give you the key parameters for you to actually guide you for your interventions and treatment in ICU. Now the temperature, for temperature, we have core temperatures. We have rectal, esophageal, and bladder. So these ones are the core temperature. They give you the real-time temperature of the patient. Now for the peripheral, you check the skin and the tympanic. So this is a measure for detection of fever, infection, and then hypothermia. So now evidence says that continuous temperature monitoring has been linked to improve sepsis detection. So now if you actually detect temperature, the patient is running fever, it's actually indication, it's an indicator for you to actually plan for sepsis and then reduce the risk of sepsis in patients. Now renal and fluid imbalance. Now, most times I used to see sometimes when I started working in ICU, I will see the nurses every 30 minutes, every hour, every 1 hour. They will go and check the urine output. Most times I will not say, does it concern me? No, it concerns everybody in ICU. Now, urine output will help you to actually track the input and output overload of patients in ICU. So this can also help you to actually detect if a patient is actually an acute kidney injuries. So now also For urine output will also help you to know if your patient is actually there is increase in urine output more than the input. If the patient is actually excreting more than the intake. So this will also help you to actually plan your intervention to know the kind of intervention, the kind of treatment you should give the patient, that this patient is actually releasing more. So I'm not supposed to actually overload the patient. I'm not supposed to overwork the patient. So now the urine output will actually give you the guide you on your treatment plans and pattern. Now the level of consciousness, GCS. I know my chief used to tell me whenever I walk into anywhere you come to the ward, make sure you check the GCS every day. Because now, if you check the GCS in the morning and come back in the afternoon and check the GCS, they are not the same. There will always be a change. And then the GCS in the morning might actually be higher than the GCS in the evening, either as a result of the drugs, either as a result of the drugs the doctors have given the patient. Now, this also helps you to actually make the proper decision for the patient and then also the proper intervention for the patient. So now, under GCS, you check the eye movement, the verbal response, the motor response. Now, you also check the alert, voice, pain, unresponsive skills for this. These are the quick bedside checks. So evidence that regular GCS scoring is predictive for outcomes in neurocritical patients. These have been supported by Tesdale et al. 2014. Now, pupil assessment. You always check your pupil, and most of the people, physiotherapists don't use to check that. You check the pupil size, the equality, the reactivity to light. So now, this helps to actually dictate the intracranial pressure, the brain inhalation, or the drug effects. So now, evidence says that abdominal pupil reflexes has been correlated to increase the mortality rate in traumatic brain injury patients. So motor response, all this is still under the GCS. Spontaneous, purposeful, abnormal posturing. Now the corticate and the celebrate positioning. So now these are essential in detecting a progressive brain injury. Now the corticate positioning is an indication for the upper brainstem injury, which includes the cerebral hemisphere, the internal capsule, or the thalamus. While the deliberate positioning is actually a extensor response, which is an indicator for damage below the nucleus or the brainstem. So if you look at the screen, you will see the corticate positioning. So in the corticate positioning, you see that the arms is always flexed, bent towards the center of the body. The wrist is always curved or bowed against the chest. Now, you also have the knee is always extended and rigid, pointed, and the toe is actually pointed towards the end. Okay, pointed towards the toe. So now, this is actually, like I said before, like I said initially, this is an indication for the injury above the brainstem, which includes the cerebral hemisphere, the internal capsule, or the thalamus. Now, for the decelerate posturing, so this is when you now see you see that the elbow is extended, the wrist is flexed, then the knee is also extended, then point and rigid pointed towards the toe. Now the arm is always tense, is always tense and then parallel towards the body. So now the vital reflexes. We have core reflexes. We have cough reflexes. Now, protection of cough reflexes protects the airway by expelling secretions and foreign materials. When a patient in ICU does not have a core reflex, it's an indication for you to actually always make sure that you have your suction machine available for you to suction, because the core reflex is not effective. So now you need to actually have your suction machine available at every point in time. When you know that the chest is already congested, you need to actually suction the patient, because the person can actually remove or produce spokesman, or actually remove those things that are actually accumulated in the chest. Now we all have a gag reflexes. So now this prevents the aspiration by triggering the throat contraction when the back of the throat is stimulated. I once heard of a story of a patient that was weaned off the ventilator and was moved to the ward. In fact, the relatives have actually prepared the bed, the luggages. They're actually planning to actually go back home. Now, the patient now said that he wants to actually drink pap. They now gave him pap. As he was actually taking the pap and drinking the pap, the patient aspirated, and that was how the patient packed. So now the patient was moved from the bed to the mortuary. So now, when the patient has no gag reflex, there's an indication for actually take a closer look at the patient. You know that patient is actually properly seated when feeding the patient. Now, for swallow reflexes, you coordinate. This coordinates safe passage of food from the mouth to the esophagus. So that the respiratory reflex, this autonomic control of the breathing, which is adjusted by the CO2 and oxygen level in the medulla and pons. So now there are some other things you also observe in ICU. You actually observe the seizure activity. If your patient is having seizure, you check the number of times the patient is actually having seizure in a day. How long does the seizure last? You understand? How long does it last? If your patient is actually restless, agitated, confusion. So these are the things that also help you to actually plan your treatment patient. So you also continue monitoring your EEG. This may be available in high resource ICUs. So now the fluid imbalance or fluid intake output chart. Now in ICU, there is always a chart where the fluid intake and fluid output is always being charted. So now they always take record of what the patient has taken, what the patient has been the output limited from urine. Now, so to also monitor the hydration, the renal function, the hemodynamic status. So this is essential in guiding the fluid therapy and preventing overloading the patient. Because if you keep overloading the patient, it also affect the kidney and all that. So now with its component of, like I said before, components, you take the intake and output, then oral fluid, the urine, the IV infusion, the enteral and parenteral nutritions. So now the clinical importance. So now early markers for organ perfusions. So now less than 0.5 mole per liter is actually a signal for acute kidney injury. This is according to Vincent et al. 2021. So now this guides of fluid therapy. So to prevent hypovolemia and then fluid overload. So now this also helps to actually improve patient outcomes. So positive accumulation of fluid imbalance has been linked with high mortality rate in sepsis. So documentation, like I said before, the importance of documentation can never be overemphasized. Take the vital signs at point A. You need to actually document the vital signs at point A. If you check the vital signs at point B, you need to actually note the vital signs at point B. If you check the vital signs at point C, you need to actually check the vital signs and you also chart your treatment. And now, if you're handing over, make sure you hand over to somebody that will take over from where you stopped. You don't just come and leave the ICU just like that and then someone will continue in the next 30 minutes. No, you must actually make sure that the person you're handing over to is available or is on ground before you leave the ICU. Now, make sure that your documentation is accurate, timely, cross-checked. Now, most times, some persons always make the mistake of actually, when they after documentation, they don't write the date, the timestamp. Now, in ICU is not just like any normal word. At every point in time, you need to actually document the date and the time. Because now, if you document the date without actually documenting the time, if you document the date without documenting the time, it's also an issue. So you need to actually document the date and the time. So anybody that comes, you know that, okay, I'm checking this vital signs every 4 hours. I'm checking this thing every 2 hours. So the person knows that in the next 2 hours, there is need for me to go and check the vital signs. In the next 3 hours, there is need for me to go and check the vital signs. So you need to actually document and must be accurate. Then also always make sure that whatever you are reading, whatever you are writing is always visible. For somebody taking over from you can actually read. You don't just write and come and write something, and then the person will now be struggling to actually read or understand what you wrote. No. Make sure that your what you documented is properly written and then accurate. So anybody taking over from you will be able to actually understand what you wrote. Now you also check your pain level. You also assess pain and comfort in ICU. So now routine periodic assessment at rest during position changes. Now, if you place your patient in hourly turning, now if you turn your patient now, you need to document what the vital signs is. If you turn again, you need to document what your vital sign is. You don't just come and tell your patient and then leave. Now, most times, like in physiotherapy has a whole lot of role to play in patients in patient in ICU. Now, positioning alone can actually increase or improve the SpO2 level. Now, you can actually prop the patient up in cardiac position and the SpO2 increases. You understand? You need to actually document that the patient was placed in cardiac position at time this. You understand? And the SpO2 was this. You understand? You document. Now, you also document before your treatment and then after your treatment. So what the vital sign says before and then what the vital sign says after the treatment. So this will also help you to actually reduce also help to actually improve patient outcomes and then reduce the risk of further complications in ICU. So we have comfort measures, non-pharmacological, positioning, padding, pressure points, adjust bedding and clothing, temperature control, soothing environment, noise, less noise. In ICU, there is no noise, lighting, enough lighting. Now, for pharmacological distinct, they give analgesic they give analgesic like opioids and non-opioids. Then adjuncts like sedatives only when needed and after pain control. So now, like I said before, documentation. Documentation is the key and hallmark. Because now, if after checking or monitoring your patient and you don't document, nobody will actually vouch for you that you actually did anything. So there is need for you to actually document every single thing you did. And then when there is need for you to communicate to other team, to communicate, then you also hand over to the proper channel. Now this will also help you to actually prevent the medical legal issue, and then also for ethical purposes. Now sometimes some patient relative might say that they don't want the patient in ICU again. Now it's left for them to actually make the decision because you're not paying it, but you also have to actually guide them and say this is the need for them being in ICU is very important. But once they say that they don't want, you stay off and then allow them to actually do what they want to do. So now you also so that you actually won't fall into trouble. Patient relative will not accuse you for actually luring them to actually leaving the patient in ICU for you to make money for the hospital. Now, so for you to actually prevent medical legal issues. So electronic health records. Thank God for technology. A lot of hospitals, so many facilities have started incorporating health record systems, whereby you actually document every single thing you do on the system, and then so that whenever anybody comes, the person can actually come and take over from you. And this is also help to actually reduce the risk of error. So that you won't come to me and you start seeing that what I documented yesterday was fail off. Because once you've documented into the system, it's already there. Nobody can change it. So now clear communication, interdisciplinary collaboration, clear communication between the nurses, physician, physiotherapists, and other ICU staffs. Now you don't just come into the ICU and start claiming God. No, we all are equal because we are there for the sake of the patient. You come, you do something that will benefit the patient. So these are the guidelines and standard. So we have WHO management and safe use for medical devices. Now we also have for medical devices in ICU. In ICU, whenever they want to take the X-rays, you always hear, please be properly be properly protected. It's either you go out of the ICU or you put on the protective gears. You understand, to prevent the risk. So you yourself will not turn to patient because you came to actually manage a patient. We also have the IEC international standard and recommendation. We also have the International Institute of ICU protocols and operational guidelines in ICU. So it's always good for you to actually make sure that you're actually following the guidelines and protocol. You don't just come into the ICU and manufacture your own guidelines and protocol, either taking the vital sign for taking vital signs or taking the other valuable important parameters. So you always follow the guidelines at every point in time in ICU. So we have different roles of ICU team in basic monitoring. So we have the core team, we have the critical care physicians, the ICU nurse, the physiotherapist, the pharmacist, the dietitians, the biomechanical engineers, and all these core teams are always on standby 24/7. Then if the therapy will not tell a pharmacist will not come and say, I'm not going, the patient doesn't need this drug. No. At 2 a.m., the patient might actually go into sepsis. They will now start looking for pharmacists to dispense the drug. So they are in ICU, everybody's always on standby. Then you hand over to the next person that will take over for you. You don't just leave the ICU. Even if you want to go and buy pure water, you don't leave the ICU. You must actually hand over to somebody while leaving the ICU. And they always document any single thing you do in ICU. So now, emerging trends and cutting edging research. So now we have some new trend that is now emanating in in patient management in ICU. A review has shown that wearable devices are now used to non-invasively monitor the heart rate, respiratory rate, the blood pressure, the glucose level, the posture, the movement, and all that. Now, even the normal normal monitor I showed initially that was showing the blood pressure, the respiratory rate are non-invasive. Now, but we'll now have a new invasive method now that check all these things: the heart rate, the respiratory rate, the blood pressure, the glucose, the posture, the movement of the patient. So this step could also help us to actually monitor patient less invasively and improve transition from the ICU to the ward. So now this is like the pictorial those emerging trends. Now you can see. Now in ICU at TNTH, you also have one. They also put that the thoracic region. Now once they place it, they just place it so they keep giving you the real values. Now one will be at the finger for the HPO to oxygen saturation level. So once the thing slips out of the patient, you will start hearing pain, 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 pain. It's an indicator that this is no longer taking the actual measurements, and then it calls your attention to you to actually know what is wrong and then fix it immediately before the patient goes. So an intelligent monitoring system for ventilator is associated events. So this according to VAS 2024. System integrated into the EMR that continually fetch data and alert physicians when ventilator settings indicates worsening. So just like I said before, now all these machines now, once the vital sign is going out of the normal range, you start hearing alerts. So this indicates the physicians, the physiotherapists to come to the patient bedside to know what is wrong with the patient and then fix it appropriately. So now early detection of this VAs also shortens the duration, reduce ventilation delays, antibiotic use, and then lower the mortality rate by 14 days. In conclusion, basic monitoring remains the cornerstones in safe ICU care, enabling early detection of deterioration, and then also helps you to actually plan your intervention and your treatment plan appropriately. The multidisciplinary teamwork ensures comprehensive interpretation and response to monitoring data. So like I said before, one discipline does not own a patient. The patient is being owned by all the units, which includes the physiotherapists, the nurses, and all that. So now, documentation, communication, and adherence to protocol. Like I said before, always make sure you document every single thing you monitor. You don't just monitor and then say, is this? And then when I come and ask, what is the patient vital sign? You start telling me, was it documented? No. So now, if the nurses accuse you that you treated the patient, you will tell them that what I did, I documented it. The patient was this when I was treating the patient was this after my treatment. Now you don't just come and you won't come and start arguing now because you already have evidence that will back your claim. All you need to do is just to go and bring up the documentation there. This is what I did, documented. This is what it was when I did my treatment. This is what it was. So nobody will accuse you that you killed the patient. Nobody will. And when there is need for you to communicate, you communicate, and then always adhere to protocols for your own safety and your patient safety. So now research and evidence supports that the clinical value of routine monitoring reduce the morbidity and the mortality rate in ICU. And also clinical value also reduce the mortality and morbidity rate, as I said before. So now including emerging trend, which includes the wearables, AI-driven analytics, multimodal monitors are transforming patients' ICU practice, making monitoring more predictive and less invasive. So now they just predict, you see the real-time values and all that. There is no need for you to actually open up the patient for you to get the real value and all that, PS the patient. So and then make sure that the patient is, and also encourage patient-centered care. So that the future of ICU monitoring lies in integrating traditional parameters with advanced technology to develop personalized and precise, safer critical care. Thank you. These are my references. Thank you so much for listening.
Thank you very much for this wonderful education. Thank you.
Thank you so much for
Thank
your
you so
presentation.
much. Let's
Enjoyed
begin with
it.
the wonderful presentation. Mhm. You can see the response from the audience is quite encouraging. I'm glad we all enjoyed it. So, based
Of
on the
course, we
lecture that
do. Thank you once again.
you're welcome. So, based on the lecture that was given, I'm sure we all enjoyed it, and it was quite impactful. As Sadaya took us through a robust route of patient monitoring in ICU, he touched a lot of aspects, both research-based, evidence-based, guidelines, and what we have to do in the ICU, how we have to work as a team, especially on documentation. I love the way he hammered on that, because the problem we healthcare are having is lack of proper documentation, and that has been overemphasized with little work being done on that. So I'm glad that we all have a robust idea of how documentation is important in ICU and how it can help save or risk life. So based on what was said, Mr. Dyer talked about various principles about monitoring in ICU. He talked about the physiological principle, the neurological principle, the hemodynamic principle, as well as the roles of various teams in ICU, as is a multidisciplinary team management in which we have the physician, the nurse, the physiotherapist, the dietitian, the med lab, and many other departments in there. He also talked about our personal safety. So as we are taking care of the patient, we don't end up being a patient as well. And based on the guidelines, he gave modernized guidelines which are up to date for the management of patients in the ICU. So thank you once again, Mr. Dyer, for the wonderful lecture. And from now on, we'll be taking questions and contribution. We will first of all take questions on this platform before we move over to questions on the YouTube channel. So you can raise your hand if you have any question to ask. Maybe Mr. Dyer can take them one at a time, or maybe after 3 questions has been asked simultaneously, he can attend to them. So does anybody have any question to ask? You can indicate by raising your hand or any contribution. Okay, I can see some question in the chat from Franklin. The first question is, how do we get up to date on evidence? The second question is, what platform are there to get this evidence? And the last question is, as an intern, do one become better in ICU? Okay, how do one become better in ICU? So, Mr. Dyer, would you like to take that while we wait for more questions?
Yes, yes, sir. Um, Thank you so much. Thank you so much for this awesome question. At least it's an interesting question. Now, the first question says, how do we get up to date on evidences? Now, we have publications on daily basis. Some people keep on publishing, and publishing. So now, you attend conferences, just like we just attended this particular training now. So these are the way you also get up-to-date evidences. Now, if you are interested, if your interest lies in ICU, you make sure that you actually attend ICU related trainings. But this is where you see up-to-date evidences, different publications from different individuals, up to them, different publications for different individuals, recommendations, and so on and so forth. Now, we also have journals. We also have ICU journals. We also have ICU related journals. So this is where they also publish up to date related journals. If you go to BMC, now you don't just go and search BMC alone. You go to BMC cardiopulmonary. You understand? This is where you will be seeing up-to-date information, up-to-date related information on ICU related issues. Now, technology have made it easy for all of us. Now you can easily browse what are the recent trends in management of patients in ICU. Now you understand. You see protocol. You see WHO guidelines there. Now we have a WHO Vision 2030. You understand, for the management of patients. Now in that Vision 2030 guideline, you don't just see only ICU. You see the neurological conditions. If you see, so these are the things you also need to actually get up to date. You don't just come and say, "Hey, I'm in analog version." You now decide not to actually go through up to date trends to know what is out there, because now you might manage your patient wrongly. So now is when you now read up materials, attend conferences, workshops, training like this and all that. That's when you have to get that's when you get up to date evidences. Now you also asked about platforms, like I said before, BMCs, workshops, like workshops, training, participate in groups like this cardiopulmonary groups. Now I love what Babatunde Ogudumade, the HOD of Unijust, has been doing. We always keep uploading information. Even my very own leader, Dr. Ezinewonsu too. They keep updating information on the groups. So now when you see something, you don't just scroll and pass. You have to actually read into it and then read and know what it's saying. You understand? If you see an argument, there was an argument that was ongoing. In fact, the argument lasted for days. And in fact, it was interesting because now from one topic to another, you keep on seeing new ideas, new information, people from different people dropping their own views. So this will also enlighten you for you to actually and prompt it for you to actually go back and read up and then know what is actually the current trend. So I don't just depend on what you've been taught in school and then this is what it is. I don't depend on textbook like my professor used to say. Gone are the days of textbooks. Because now textbook gives you the guideline, but research and evidence gives you up-to-date evidence of what you do need to do for the patient. Now, as an intern, how do one become better in ICU? Now, for instance, you don't become better in what you don't have interest in. That's the principle I work with. If your interest is not in ICU, you can never become better in it. So now, first of all, you have to actually develop interest and also develop affinity for it. For you to now, and then you also always have to ask this question: why? Why is this so? You understand? You also ask everything you see. You also have ask why. They know the reason, and then on daily basis, you see that you see that every day is a better version of you. So you also but then one of the issues we always have in this profession is that most times in different centers they don't have specialized centers like we do in Enugu. Some centers are not up to this and the ICU we have up to the standard of ICU we have in UNTH. Now you just attend conferences until you have the opportunity to actually become or come to a center that has those specialized facilities, and then you also attend workshop like I said before. Now, for instance, now if your interest is in ICU and you know that probably Unibadan or University of Ibadan Teaching Hospital has a center of cardiothoracic center. Now you might start asking to go there for your internship. You understand? So by doing so, this also exposes you to different facilities, different here or how they do this over there, and then you also have to. This also help you to actually develop yourself the more. Thank you. So I can see Success Abel raising his hand.
Okay, please
I actually want to.
let's take the next question.
Can I go ahead?
Hands.
Yeah.
Hello. Hello.
Ed.
Can anyone hear me?
Yes, I can hear you.
Can hear you.
Yes, I can hear you.
Okay, I'm saying let's take the next question on the chat, then we can move over to those that raise their hands. So the question on the chat says, what's the relationship between SpO2 and intracranial pressure? Did you get me, Sadayo?
Come again, what do you say?
What's the relationship between SpO2 and intracranial pressure?
Okay. SpO2 it gives you the level of oxygen level of oxygen saturation of the patient. Now, why the SpO2? Why the intracranial pressure? gives you if there is elevated compression on the cerebral blood vessels or the blood vessels in the brain. So now low SpO2 can increase vasodilation. You understand? And then increase intracranial pressure. Then why increase in oxygen increase in SpO2 can cause vasoconstriction and reduce intracranial pressure. So when there is actually low oxygen saturation, the blood vessels tend to actually constrict, and then there will be increase in intracranial pressure. So now, which will in turn increase hypoxia in the patient. So when there is increase in oxygen saturation in the blood vessel, there will be vasoconstriction. The intracranial pressure tends to actually reduce. But then, when there is increase in oxygen saturation, when there is decrease in oxygen saturation, there is vasodilation. Now, there is increase in intracranial pressure, less perfusion, more hypoxia. Do you understand? Can you hear
Sorry, sir.
me?
Can you come
Yeah.
again, sir?
Okay, now when there is low SpO2, and then it leads to brain hypoxia, and then there will be constriction, there will be vasodilation. The vasodilation of this blood vessel, which increases the intracranial blood pressure, because now the SpO2 has formed below the normal. The brain senses hypoxia, which is a low oxygen. So in response to that, the blood vessels tend to actually dilate to increase blood flow into the brain and oxygen delivery. So then when there is increase in blood flow to the brain, now there's also increase in intracranial pressure. I come again. When the SpO2 when the SpO2 reduces, the brain senses hypoxia. There's vasodilation. The blood vessels tend to actually open up. Now there is increase in intracranial pressure. How? Now when the SpO2, when the brain senses that okay, now the SpO2 is actually reduced, they will dilate. Now there will be rush of blood to the brain to deliver oxygen into the brain. So now as they are actually rushing into the brain, there is increase in the intracranial pressure, and then or rise in the blood volume in the brain, which will actually cause the increase in the intracranial pressure. So now when there is high intracranial pressure, they reduce cerebral perfusion and then worsen this hypoxia. You understand? Then elevated intracranial pressure can also compress blood vessel, reduce perfusion pressure, and then also reduce this oxygen delivery to the brain. And then this cycle also continues. They keep on continuing. That's why the intracranial pressure keep on reducing. Now the blood vessel, the blood vessel keep on dilating. The blood keep on rushing to deliver more blood. Now the intracranial pressure keep rising. So I don't know if you understand. So that's the relationship between the intracranial pressure and then SpO2. And then it can be seen in patients with head injury and this brain edema, swelling in the brain. I don't know if you understand, if you get me.
Yes, I understand, sir. Thank you very much for the answer.
Okay, Stella, you can go ahead now. Hello, Stella.
We're still waiting to hear from you. Bro, good evening. Sorry for the
Okay,
response.
Mr. Matum.
The test was taken by
Would you like to ask any questions, sir?
student took the test.
Oh, shucks. I didn't see that my mic was still muted. I was saying I don't have much to say or to ask, but to ask for the slides to be shared with us on the WhatsApp group.
Okay, that will be shared immediately the class is over, sir.
Okay, okay, no problem. Thank you so much.
You're welcome, sir. So, any other question? I checked the YouTube group and there is no question there.
I
So,
want
if
to
there's any,
make a contribution.
okay, Chief, you can go ahead, man.
Okay, good evening, everyone. Thank you, Dio, for that detailed presentation. I want to like commend that intern that asked that question. How do one become good in patient monitoring? Patient monitoring in ICU is a very serious business because that is the only way you can keep patients safe, and it's also the only way you can also understand the progress of, of patients that you are managing. So I want to encourage the intern or any other person, if you want to be good in patient monitoring, you should read articles. You read articles, you engage in a lot of training. There's no shortcut to success. You will attend conferences, attend seminars, just like you have done today. Then you go online, you look at research work people have done. And one thing with ICU care is that it keeps evolving. Before, we were taught that when you want to put a patient on vent, you will use the weight of the patient. By that time, we are using 10 mil per kg of a patient. But after a lot of work were done with regards to patient being ventilated and volume trauma in patients that are ventilated, research now says it shouldn't be I think 10 mil per kg. So if you want to put a patient on vent now, the volume you give the patient is actually lower than the patient's weight. I think it's 6 to 8 kg per mil now. So if a patient weighs 70 kg, before you'll be giving that patient 700 mil. But now, if a patient is weighing 70 kg, you'll be giving the patient between 400 and 500 mil of volume of oxygen or ventilation. So it keeps evolving. So I want to encourage us not only textbook. In fact, these days, most times we don't even read textbook. We go online to find out what researchers have done. People that are ahead of us, or people that are doing great work in area of ICU. You have your physiology at the tip of your finger. You need to understand physiology very well. If you understand physiology as a physiotherapist, you will love being a cardiopulmonary physiotherapist because it's all about exercise. How does the body respond? What should I do in this situation? How do I manage this patient? How will the body cope with oxygen delivery, perfusion, the shunting, and things like that? So I also encourage the students, the interns, please dust your physiology textbook and keep it very close to you. Even up till now, I still read physiology. Sometimes I check what is the relationship between this and this, and it keeps helping you to get the picture clearer. So thank you, Dio, for the presentation, and thank you for everyone that has stayed on till now. Thank you.
Thank you so much, Chief, for the conclusion. That was quite inspiring. I want to be an ICU physiotherapist now. All right, so with that, we have come to the end of today's section. Chief, hope I can go ahead and conclude the section. No other contribution, right? Okay, thank you so much, everyone, for your time. We appreciate you giving us this evening to impact and to learn, because as we teach, we also learn. As we listen, we learn. So if you have any other question or any other input, you can drop it on the group chat. Sadaya and my chief, Pitiezine, will do justice to that. And in the absence of any other contribution of questions, we come to the end of this section. Good night, everyone. Have a nice night.